Bismillah ar-Rahman ar-Rahim. I'm Dr. Mohamed Hassan, Associate Professor of Cardiology at Cairo University. In my talk, we will focus on non-pharmacological management of heart failure. If we imagine that the failing heart is like a sick, tired horse pulling a wagon up a steep hill, so the application of a whip will encourage the horse to move faster. However, it may kill the horse, which is exactly similar to what inotropes do in patients with acute heart failure, like in the ESCAPE trial. You may instead unload the wagon and decrease the preload and the afterload of the heart by using ECI, ARPs, ARNI, diuretics, which is very helpful and improve the prognosis and symptoms of heart failure for the patients. You may slow the horse and slow the heart by using beta blockers, which has significant survival benefit, and also ivabradine, funny current blocker, which improve the heart failure symptoms. You may think to heal the horse and do coronary revascularization, which may improve the LV function and improve the heart failure symptoms and prognosis of the patients. But unfortunately, despite all these measures, still the 5-year mortality for patients with heart failure reach up to 50%. And in those with refractory heart failure, stage D heart failure, still the 5-year mortality reach up to 80%. So in these cases, you should think of a non-pharmacological option, like getting a tractor, getting a device that either electrical or mechanical device that improve the LV performance and prevent mortality in those patients or decrease mortality in those patients. Or you may get a new heart and do heart transplantation. Let's focus on the device therapy in patients with heart failure. A significant proportion of heart failure patients have substantial LV dysynchrony due to intraventricular conduction delay, with delay in the peak systolic velocity of the lateral wall compared to the septum, which lead to LV systolic dysfunction, more mitral regurg, aggravation of heart failure symptoms. And there is a graded increase in the mortality with increasing intraventricular conduction delay. So with more intraventricular conduction delay, there is more dysynchrony, there is more mortality reflected because of the aggravation of heart failure symptoms. And intraventricular conduction delay correlate on the surface ECG with the QRS duration. There is a positive correlation between the intraventricular conduction delay and the mechanical dysynchrony with the QRS duration. So with prolongation of the QRS duration, you are expecting more dysynchrony and more LV dysfunction, which will reflect on the symptomatology and prognosis of the patient. There are two important studies, the companion study and the CARE heart failure study, which compared CRT, the cardiac resynchronization therapy in patients with wide QRS duration, to pharmacological therapy in patients with advanced heart failure. And in the companion study, they found that CRT lead to significant improvement in the primary endpoint, which is the death and hospitalization from any cause, and also the secondary endpoint, which is the death from any cause. So implanting CRT in patients with wide QRS lead to improvement of the heart failure symptoms and improving the prognosis. And in the CARE heart failure study with long-term follow-up, there is a 36% relative risk reduction in the total mortality or the death from any cause. As we are expecting that the benefit from CRT may be due to just its pacing effect and managing the bradycardia events that may happen due to the use of beta blockers or funny current blockers in heart failure patients. So in the MADIT CRT study, they compared the CRT ICD to ICD to see is the benefit from CRT is related to improving the dysynchrony rather than managing the bradycardia events that may happen in patients with heart failure. And definitely, implanting the CRT in symptomatic patients with wide QRS lead to 41% relative risk reduction in the heart failure events. And with long-term follow-up in the MADIT CRT up to 5 years, they found that mainly patients with left bundle branch block who got benefit from implanting CRT. So patients in the group of patients with left bundle branch, there is a significant mortality benefit from the CRT. However, those with no left bundle branch block, there is no benefit. And when we combine the QRS duration with the QRS morphology, for example, in the NCDR ICD registry, patients with left bundle branch block got benefit from CRT if the QRS duration 130 millisecond or more. But if there is no left bundle branch, the patients may get benefit from CRT if the QRS duration 150 millisecond or more. So you need longer duration of the QRS in patients with in patients with no left bundle branch block. So what does the guidelines say? In the European guidelines in 2016, the guidelines is clear that there is no benefit from implanting CRT in patients with QRS duration less than 130 milliseconds. That's a class 3. However, there is a class 1 recommendation. You should implant CRT in patients who are symptomatic despite optimal medical treatment, who are in sinus rhythm with LV ejection fraction is 35% or less, and if they have left bundle branch block with QRS duration 130 milliseconds or more. So once the QRS duration is more than 130 milliseconds in left bundle branch block, this patient is eligible to put a CRT if he's still symptomatic despite optimal medical treatment for 3 months. But if there is no left bundle branch in the surface ECG, it's reasonable to put CRT if the QRS duration 150 milliseconds or more. But it's not recommended, or there is no significant benefit if you put a CRT in patients with no left bundle branch and the QRS duration between 130 and 150 milliseconds. There is also important recommendation that if your patients with heart failure and reduced ejection fraction, he has LV systolic dysfunction, regardless his symptoms, and has indication to put a pacemaker. So it's better to put a CRT rather than RV pacing, because biventricular pacing, just RV pacing, will lead to more deterioration of the LV function. So it's better to do a biventricular pacing in those patients. And what about patients with atrial fibrillation? It's reasonable in patients with atrial fibrillation who are symptomatic, but you should be NIHA class 3 to 4 to put a CRT, but you should ensure biventricular capture in those patients, either to do AV nodal ablation or strict pharmacological rate control to ensure that most of the time the two ventricles are paced by the CRT device. What about the response? We know that 25% of patients who we put CRT for them, they will be non-responder. There is no benefit, there is no response in terms of LV function and symptomatology, but the patients could be a responder or even sometimes super responder. We are expecting a response if you put the CRT according to the guidelines up to 75%, and the rate of non-responder reach about 25%. This is for patients with heart failure and wide QRS duration. What about those with normal QRS duration or the QRS duration less than 120 milliseconds? There are many devices. One of them is the cardiac contractility modulation, CCM. It's implanted similar to CRT with 2 leads implanted in the med septum from the right side and 1 lead in the atrium. And this device sends a non-excitatory impulse during the absolute refractory period, about actually it's 30 milliseconds after the QRS duration. And it does not induce a new contraction. However, it potentiates the systolic contraction of the ventricle, mainly by increasing the phosphorylation of phospholampan, improving calcium handling acutely, and also the long-term expression of genes and proteins involved in the calcium handling process. So in patients with normal QRS duration, you may put this device to enhance the cardiac contractility, and this study showed that CCM in patients with normal QRS duration improved the oxygen consumption, improved the symptoms, improved the quality of life in those patients. There is other devices under investigations like spinal cord stimulation, carotid baroreceptor stimulation, cervical vagal nerve stimulation, and the most promising of them is the carotid baroreceptor, or what's called baroreflex activation. And actually the FDA recently gave breakthrough device designation for what's called Prof.Dr. new device. This device implanted just below the clavicle with a lead stimulating the carotid baroreceptor to increase the vagal tone, decrease the sympathetic drive in patients with heart failure. And this is actually based on a recent trial published in the Journal of American Cardiology, American College of Cardiology this year. It's called Beat Heart Failure Trial. And in this trial, this Prof.Dr. new device improved the exercise capacity, quality of life, and with significant reduction in the N-terminal proBNP, up to 25% reduction. So it improved the quality of life in patients who are symptomatic still despite pharmacological treatments. What about prevention of sudden cardiac death and implanting an ICD in patients with heart failure? ICD mainly is recommended either for secondary prevention or primary prevention. Secondary prevention, if the patient is a survivor of cardiac arrest or he developed ventricular arrhythmias causing hemodynamic instability, but he should have an expected survival 1 year to put an ICD for those patients. For primary prevention, if the patient did not develop any ventricular arrhythmias before, still there is a class 1 recommendation to put an ICD to prevent sudden cardiac death in patients who are symptomatic, so they are class 2 or 3, despite an optimal medical treatment for at least 3 months. Either they are ischemic or non-ischemic cardiomyopathy. But there is a class 3 recommendation, so it's not recommended to put ICD in patients with advanced symptoms who are in class 4 with severe symptoms refractory to the medical treatment, because these patients actually have very, very limited survival, so they will not benefit of ICD, except if you are thinking to put CRT or a VAD, or thinking of a mechanical assist device or even heart transplantation. But we know that there is a new study, actually it's not new now, it's in 2016, but the Danish study actually doubted the benefit of ICD as a primary prevention in patients with non-ischemic cardiomyopathy. And in the Danish study, it showed there is no benefit in terms of total mortality or death from any cause in patients with non-ischemic cardiomyopathy. So there is a clear benefit definitely in patients with ischemic cardiomyopathy, but now it's doubting that the benefit of ICD as a primary prevention in patients with dilated non-ischemic cardiomyopathy. But still the recommendations now in the guideline, they put in both in ischemic and non-ischemic cardiomyopathy. This is for what's called electrical devices, either aimed to improve the ventricular performance and improve heart failure symptoms, or prevention of sudden cardiac death. What about mechanical circulatory support and putting ventricular assist device in patients with refractory heart failure? As we know that cardiac transplantation is available only for a minority of patients, either during donor shortage, there is less than actually 3,000 donor organs worldwide per year, with actually it's fixed number. There is no actually there is no increase actually in this number, or no expectation to increase the number of cardiac transplantation worldwide, so it is a stationary course. Many patients die actually on the waiting list of transplantation. In many countries, there is no transplantation programs like here in Egypt, and we know patients that have contraindication to transplantation. So in this patient, all this stimulated the need to use a mechanical device to unload the ventricle and improve prognosis and symptoms in refractory heart failure patients. And back in 2001, actually, it was the landmark trial, which is called the rematch study. This is actually a landmark trial which randomized patients with refractory heart failure with reduced ejection fraction, to the first generation pulsatile ventricular assist device, which is HeartMate VE VAD. This VAD actually, it is a very large one with a mechanically driven volume displacement chamber implanted in the peritoneal cavity, mainly to unload the ventricle and to pump the blood from the LV to the aorta to improve the cardiac output and to unload the ventricle and improve the ventricular performance. And this actually landmark trial showed a significant survival benefit. There is improvement in survival that actually at 1 year reached around 52%, with a 2-year survival about 25%, which is much better than pharmacological treatment in those patients. And then with the development of the continuous flow pumps, the first one is the axial pump, the HeartMate 2. This actually, it was a major step forward in the development of ventricular assist device and management of refractory patients. Actually, it is a small rotary pump with a magnetically levitated pump with less fraction, less mechanical contact that pump the blood from the LV to the aorta, but this pump still implanted in the peritoneal cavity below the diaphragm. It's much smaller than the first generation, which actually reflected in better performance, less adverse events, less device dysfunction, and less incidence of thrombosis, embolization, and even bleeding. And in many studies, actually, the continuous flow LVAD showed significant survival benefit compared to the pulsatile flow LVAD, with improvement of the 2-year survival from, as we said, 25% with the first generation ventricular assist device, improved up to 60%. So the 2-year survival with the second generation continuous axial flow pump reached up to 60% with less adverse events compared to the first generation pulsatile ventricular assist device. This is the third generation. The third generation continuous flow pump, it's very small compared to the second generation centrifugal pump, which is implanted in the pericardial cavity. So it's not below the diaphragm. It's a small pump implanted at the apex, small centrifugal pump the blood from the LV to the aorta with better hemocompatibility. Actually, it needs low RPM, so there is less shear stress, less hemocompatibility, better performance, and actually this is reflected in many studies that the survival benefit is better and the adverse events is better with this centrifugal pumps. But it's very important to know that despite that it's a continuous pump, but still there is some pulsatility, as we see here in the graph below. There is still some pulsatility generated by the contraction of the ventricle and the blood going through the aortic valve rather than the blood going through the device itself. So it's very important not to completely unload the ventricle and allow some blood to move along the aortic valve to ensure that there is some flow crossing the aortic valve. And this pulsatility is very important because it avoids fusion of the aortic leaflet, which may lead on the long term some aortic regurgitation. Also, it avoids some thrombosis on the aortic valve and embolization, and also it gives some it's a physiological condition with some pulsatility similar to actually the normal pulsatility for the patients, which better perfusion of the peripheral microcirculatory bed. This pulsatility mainly is determined by the degree of LV unloading, which is a pump speed. So you should have the highest pump speed, but that allows some flow across the aortic valve, and definitely depending on the degree of LV contractility. This is actually the advanced study, which studied the third generation centrifugal pump, the HeartWare study, which will actually prove that it's non-inferior to HeartMate 2, the second generation. But with the Momentum 3 study, the HeartMate 3 actually has better survival and less adverse events compared to the second generation HeartMate 2. VADs can be used as a bridge to transplantation, and worldwide 40% of the patients who have heart transplantation actually puts a ventricular assist device as a bridge to transplantation, either just to keep the patient compensated till finding a heart for him, or actually if he have some contraindication that actually improved on the VAD, so he became eligible for heart transplantation. That can be used as a bridge to recovery even in patients with chronic heart failure, and we actually have a landmark study published by Jakub group that actually showed that implanting ventricular assist device with optimal medical treatment in young patients with dilated cardiomyopathy, non-ischemic cardiomyopathy, allowed explantation in up to 75% of patients and recovery of this ventricle with no recurrence of heart failure events in 88% of those patients up to 5 years follow-up. So, but this actually restricted to young patients with non-ischemic cardiomyopathy. So that can help in recovering the LV function even in patients with chronic heart failure. Can be used as a rescue therapy in patients with acute heart failure till either recovery or transplantation, or if the patient did not recover, so he may continue on the VAD as a destination therapy. And finally, VAD can be used as a destination therapy, and there is now year by year increase in the utility of VAD as a destination therapy. So the patient live actually with the VAD with the optimal medical treatment. And it's very important to know which patient actually you should refer to put a VAD. According to the old rematch study and also the new HeartMate 2 study, and also the studies which studied the third generation VAD, the patient should have severe LV dysfunction with an LV ejection fraction less than 25%. If the patient is inotrope dependent, so definitely this patient is eligible for VAD, or if he has severe symptoms with class 4 despite optimal medical therapy for at least either one study showed 90 days on optimal medical treatment or 60 days on optimal medical treatment. If he is ambulatory, so you can measure the peak oxygen consumption, and if the peak VO2 less than 12 to 14 milliliter per kg per minute, so this patient is eligible for VAD. Actually, the Intermax, which is the largest registry on mechanical assist device in North America, have categorized patients eligible for VAD into 7 categories or 7 profiles. The first category, those with critical cardiogenic shocks that were crashing on inotropes. Profile 2, patients who are on inotropes with progressive decline and progressive deterioration despite escalation of inotropes. Group 3, who are stable but they are inotrope dependent. Once you wean the inotropes, the patient cardiac output decrease and blood pressure drop and the heart failure recurs, so they are inotrope dependent. 4, they are not on inotropes but they are frequent flyer. There is a repeated and recurrent hospitalization actually because of heart failure symptoms. Profile 5, they are exertion intolerant. They actually cannot do any activity, but they are at rest, they are fine. Profile 6, patient that can do some minor activity, but once he got into any meaningful activity, so he cannot actually withstand and he cannot actually live a normal life. And profile 7, the patients with advanced class 3 heart failure. And if we look at actually the data from Intermax, we will find that 2/3% of patients who had VADs, they are either category or profile 2 or 3. And there is a clear trend toward doing less patients in profile 1 who are crashing on inotropes, and a clear trend toward doing more patients in profile 4 as a totally elective procedure before deterioration. And actually this patient have better outcome than doing a VAD on later stage with more deterioration of the liver or kidney function. This because the mortality in patients with profile 1 who had VAD is very high. Actually, the in-hospital mortality reached up to 30%, and the hospital stay significantly higher than the other profile. So it's now there is a clear trend worldwide not to do more patients in profile 1, the patients who are crashing on inotropes, and it's better to do it on a relatively stable condition. This patient have a better prognosis, not only on the short term, but also in the long term. Patients actually with profile 1, even if he survived the in-hospital period, the long-term survival is significantly lower compared to those with profile 2, 3, or 4. Importantly, there is many challenges in patients with VAD. These are a sick group of patients, have a major surgery with a significant bleeding actually during the surgery. They have high mortality, the cost is very high, the pump is really costly, reach actually $1 million at a time. There is some cultural points that should be discussed, because the patient should know that there is a drive line coming outside and know how to deal with this device. Should have some psychological support from the caregiver living with him. This device is associated with many related adverse events. This device needs very close follow-up, but despite all this device, still the benefit and the survival benefit outweigh the risk. As we said, there are many adverse events, either non-device related due to right ventricular failure. Once you unload the ventricle, the LV with the pump, there is increase in the systemic venous return, which increase the load on the RV. So if this RV has some subclinical RV dysfunction before the operation, actually it may fail and distend after the operation, and this actually will compromise the LV performance and may decrease the cardiac output. And there is many predictors for the RV failure after putting VAD. There are female gender, the non-ischemic etiology, if there is an elevation in the liver function and the kidney function due to high systemic venous pressure, if the hemodynamic parameters show high central venous pressure or high transpulmonary gradient, if the echo actually showed RV dysfunction or severe tricuspid regurg, all these give predictors to RV failure post-VAD. So accurate assessment of the RV function before implanting VAD is very, very important. There are many adverse events for patients who had VAD, either non-device related, right ventricular failure, because once you implant VAD and unload the LV, there is increase in the systemic return, which increase actually the load on the RV. And if the RV have some subclinical RV dysfunction, so it may fail and may distend after putting a VAD, and actually compromising the LV function and decreasing the cardiac output. And there is device related complications like acquired von Willebrand syndrome, the increased bleeding, also the thromboembolic events. We know that patients on VAD should receive antiplatelet and anticoagulant therapy, and using warfarin with a target INR reach up to 3 in order to decrease the risk of device thrombosis and also the thromboembolic events. Also very important, the drive line infection, and the data actually, the freedom from infection with LVAD reach only 40% at 2 years. So at 2 years, 60% of patients actually got infection. This is very important challenge with VAD patients. Important points, there is no age limitation for VAD. Importantly, the patient should have some psychosocial support. The mental state should accept actually putting this device with the drive line coming out from the abdomen to a battery and controller outside. It can be implanted down to a body surface area of 1.5, but actually it can be used for pediatric patients. There is contraindication to put VAD in patients with dialysis. Severe pulmonary hypertension is a contraindication for heart transplantation, but with VAD, it can be used especially if it's secondary to heart failure, not due to intrinsic lung disease. Accurate assessment, as we said, for the RV function before putting a VAD is very important. There is actually a risk score that you can be used to predict the outcome after VAD, mainly actually related to know the albumin, the liver function, the pulmonary artery pressure. Finally, there is also a new device that can be used to decrease the left atrial pressure and unload the ventricle. It can be implanted percutaneously, the Corvia interatrial shunt device, which actually decreases the left atrial pressure. This actually the FDA gives him a breakthrough device designation for heart failure with preserved ejection fraction. If the patient is symptomatic with high left atrial pressure, this device can lead to left to right shunt, decrease the left atrial pressure, which improve the patient's symptoms. Finally, we can summarize the non-pharmacological and device therapy in heart failure patients. There is either electrical or mechanical device. Electrical device, either CRT in patients with wide QRS complex, CCM cardiac contractility modulation in patients with normal QRS, the carotid baroreceptor stimulation, ICD for prevention of sudden cardiac death. We have the mechanical devices, either ventricular assist device or interatrial shunt device in patients with heart failure with preserved ejection fraction. Thank you.